Hello, everyone. Um,
Hello. Hello, good evening, everyone.
welcome to the 38th MENASO Education Academy Cerebrovascular Grand Round and the second webinar of the year. The webinar series has successfully brought together a global community of more than 7,500 participants last year, success attributed to our esteemed lineup of 28 speakers, including local and international renowned professors and consultants. To explore the intricate landscape of cerebrovascular medicine with Dr. Shuaib and Dr. Francesca, as well as presentations of case studies by Dr. Hashimi and Dr. Khadija as well. Our first topic will be for symptomatic basilar stenosis by Dr. Mohammed Al-Hashimi. Dr. Mohammed Al-Hashimi is a senior neurology resident in Kuwait Neurology Board Program and former chief resident for 2 consecutive years. And he has been a quite active participant in community awareness programs, activities highlighting secondary stroke prevention. Dr. Hashimi, the mic is yours.
Good evening, everyone, and thank you, Dr. Salmin and the MENASO organization for it. So I'll just start over with the presentation of this gentleman. So he's a 61-year-old male with a history of bilateral glaucoma and right CRVO, presented with sudden onset of dysarthria and positional vertigo. His initial symptoms lasted for 2 minutes at home, and when he presented to the emergency, he also had recurrent transient symptoms in the emergency. Upon examination, his NIHS was 3, and then it reverted to, or improved to 0. And his blood pressure at that time was around 175/100. So the patient had a CT scan done alongside the CT angio of his brain. And this is the initial CT scan, but over here we have a maximal intensity projection of his brain alongside the CT scan that we initially did. And in the beginning, we can see that the patient actually had a proximal stenosis of his basilar artery. So I'm gonna take my time while flipping through the images so that you can actually appreciate where the stenosis is. I have a couple of images throughout the presentation. So the patient was admitted and treated as a TIA at that time and started on dual antiplatelets. So aspirin and clopidogrel were initiated or started, and the patient was put on atorvastatin as well, and he was diagnosed with new hypertension. Stroke workup was also being done while he was in the hospital. His ECG was sinus rhythm. His HbA1c was within acceptable range, 5.3, and his LDL was elevated. An echo was also done showing his ejection fraction to be over 55 with left ventricle size, thickness, and systolic function were also normal. He had pseudo-normal left ventricular filling pattern, which is consistent with the elevated LA pressure. So his left atrium was mildly dilated. On the following day, the patient underwent an MRI brain. Now the qualities can be the quality is not that amazing, but on the DWI we can see actually a restricted diffusion in the right cerebellum, and it's not showing on the ADC, but we can also see it on the T2. So the patient stayed in the hospital for 5 days, and during his hospital stay, didn't have any recurrent spells or any symptoms, and his NIHS was actually 0 throughout his stay. So dual antiplatelets were planned for 3 months. So aspirin and clopidogrel were planned for 3 months, and the patient was adherent to his medications. The patient was discharged, but unfortunately, after 23 days, the patient presented to the emergency department again. And this time he was actually complaining of a 1-week history of intermittent left-sided numbness. Each spell was around 10 minutes or even shorter than 10 minutes in duration, and they were non-positional or provoked. While in the emergency department, the patient had his blood pressure elevated, so it was around 140/98, and the patient also developed, while he was in the emergency, right-sided facial droop alongside dysarthria, lasting for around 10 minutes. A CT scan was also done at that time. So this is the same imaging modality that I was referring to earlier on, and we can still see the proximal basilar stenosis. Here, I'll just have my pointer at it. The patient, and following day, the patient also had a MRI done. Hello? Yeah. The following day, the patient also had an MRI done, and it showed a right pointine DWI restriction, which couldn't be appreciated on the ADC, but it was also showing on the flare, T2 flare. And so the patient was started on antithrombotics. Sorry, his antithrombotics were changed from aspirin, were changed to aspirin and therapeutic Lexane. His labile blood pressure early on was left. The patient was monitored during the hospital stay, and the patient was having a recurrent and persistent left-sided numbness and vertigo. A repeat of his MRI was also done after a couple of days, which surprisingly didn't show the right pointine DWI restriction that was shown earlier, and wasn't also visible on the T2 flare. So in these two images, they were showing in the first time he did his MRIs, and we were thinking that, or we were actually pinning down his symptoms to those lesions. But when we repeated the MRI, the patient didn't have his the lesions. So the patient was started on anticoagulation. After 1 week of anticoagulation for plaque stabilization, we repeated a CTA for the patient, and the patient was stable, non-symptomatic. So after having the patient being stable for 1 week and his NHS was actually 0 and he didn't have any recurrent spells, the antithrombotics at that time were actually switched to aspirin and ticagrelor. Now, with basilar stenosis, the incidence of basilar stenosis is quite rare. The incidence is around 1.4%. And the most common areas for basilar stenosis are actually the proximal segments, which is what we actually had with our patient. And the annual stroke risk for patients with symptomatic basilar stenosis is around 11%. Okay, so when we come to the literature of the management of basilar stenosis, there is no randomized control trials for basilar stenosis management, and most of the information that's available in the literature is actually observational and case reports. So there is no definite management when it comes to how to deal with patients who actually have patients who actually have basilar stenosis. Our patient had minor transient symptoms alongside his basilar stenosis, and there was no occlusion. So we've sent for him vasculitic screen, and we actually modified his medications, and we started the patient on ticagrelor and aspirin based on the findings of the TAILS trial, and that patients could be on the dual antiplatelets or ticagrelor and aspirin. And just to highlight that we didn't change from clopidogrel to ticagrelor because of failure of clopidogrel. We actually changed it due to the fact that in the TAILS trial, which was studied, was the second agent, which is the ticagrelor and the clopidogrel. And so far, we're actually waiting for the pending workup for vasculitic screen for this patient. And we actually also, one of the things that we did for this patient is that we liaised with the interventional radiology. So there was a liaise between the intervention team and the stroke team, and both agreed that the patient is not to proceed with intervention due to the fact that the patient was having lack of persistent symptoms and disability. So at the end, we tailored the medication to put the patient on those two agents, and the patient so far is symptom-free. Thank you.
Thank you. Thank you, Mohammed, for this excellent presentation.
Thank you.
So I think we move to the second presentation, which is management of early pregnancy ischemic stroke by symptomatic carotid artery dissection, presented by Dr. Khadija, who is a young neurology resident in active training and in the neurology department of Blidhouse University Hospital in Algeria. And she is aspiring in the field of cerebrovascular diseases. You can start, Khadija.
Hello, everyone. I thank the Academy, the MENASO Academy, for the invitation. So I am happy to present before you today my presentation about the management of early pregnant ischemic stroke by spontaneous carotid artery dissection. I'm just gonna check this. So as an introduction, hemodynamic and hormonal changes occurring during pregnancy, especially in the peripartum, being a predisposing risk factor for arterial dissection during pregnancy, related carotid artery dissection is still an entity that needs to be discussed and elaborated for better maternal and fetal outcome. So we have a case highlighting this entity, which is the case of a 32-year-old female. She has no special medical history except 2 early spontaneous miscarriages, 2 full-term pregnancies, and presenting with a 7 weeks evolutive viable pregnancy at time of admission. For her clinical history, our patient presented on December 1st, 2023, as sudden onset symptoms of muscular weakness of the left hemibody with blindness of the right eye. Her symptomatology subsided spontaneously and totally within 24 hours. Our patient did not seek medical attention. On December 3rd, 2 days later, the patient presented with sudden onset of muscular weakness affecting the same hemibody associated with intense neck pain. Our patient finally sought medical attention 24 hours later. No traumatic, minor or major events were reported at interrogation. For her neurological examination, it found a cooperative conscious patient. Her cranial pairs examination was normal, especially the examination of the optic nerve. Her long tract examination found a partial but non-proportional left hemiparesis with brachial predominance. Her somatic examination was without anomaly. So in total, it's the case of a 32-year-old female pregnant patient at 7 weeks of gestational age with a history of 2 early spontaneous miscarriages, who presented with a sudden onset proportional left hemiparesis with neck pain preceded 2 days prior with sudden, total, but regressive visual loss. So we are going to try and give a diagnosis hypothesis. So we have the first episode of amaurosis fugax, which is the total loss of vision at the right eye, which indicates that the patient might have had a retinal artery occlusion. Retinal artery being a branch of the ophthalmic artery, also a branch of the internal carotid artery, alongside her left hemibody hemiparesis with brachiofacial predominance that would indicate an MCA occlusion, which is also a branch of the internal carotid artery. Alongside neck pain, this would orient us towards our diagnosis hypothesis, which is carotid artery dissection. We know that carotid artery dissection is suspected in all patients with acute or subacute headache, neck pain, stroke symptoms, cranial or cervical neuropathies, and even in patients with tooth pain without dental cause. Particularly in the following settings of trauma, even minor or trivial, participating in sports, physical activity, intense sneezing or coughing, peripartum valsava, and personal or family history of connective tissue or vascular disorders or migraine. So we conducted an MRI at our patient, and it evidently showed a double MCA infract, right MCA infract, but with 2 different hyperintense lesions, one for the superficial territory and one for the profound territory. For her 3D time of flight sequence, we find a double lumen appearance, suggesting an internal carotid artery dissection, or what we call a flame sign. On the 3DT1 FATSAT, we find a crescent sign, all suggesting that the patient did indeed have an internal carotid artery dissection. So while looking for the etiology of this dissective event, we interrogated the patient, her husband, her family about if she had engaged in any of the following activities. The patient did not. For other etiologies, such as fibromuscular dysplasia, Ehlers-Danlos syndrome, Marfan's syndrome, and other conjunctive tissue disorders, our patient did not have any family history of aneurysms, dissections, spasms, sudden deaths. Her physical examination was normal, and her MRI did not show any signs favorable of these diagnostics. So we did not have any hypothesis for her condition. So what about pregnancy and carotid artery dissection? As you know, carotid artery dissection in pregnancy has been the main subject of study of many large group cohorts that elaborated the relation between hemodynamic and hormonal changes, leading to arterial wall breaches. From the works that have been made, we are going to mention three major cohorts. The first one is the Salhi Omran cohort, the American cohort, that studied the 826 pregnant patients who were controlled versus perfectly matched 826 pregnant patients who were admitted for renal colic. The second large cohort was the Bayer cohort of the Harvard University, which studied a nationwide cohort of approximately 18 million pregnant patients, among which almost 1,000 patients presented with pregnancy-related artery dissection. The third cohort was the Traeger cohort that studied almost 920,000 patients, pregnant patients who presented with among which 900 patients presented with artery dissective disease. So between the results, I tried to gather the results of these cohorts. The first major result was that women have nearly twofold increase in risk of developing carotid artery dissection during pregnancy and the peripartum period compared to non-pregnant controls. The second main result was that dissections occurred in the postpartum period with a percentage of 61.5% of cases, followed by dissections during delivery, then dissections in the antepartum. Most postpartum readmissions associated with the dissective disease occurred within 30 days of delivery, compared to patients with a dissection prior to or during delivery. Those with a dissection in the postpartum period were older. They were more likely to have gestational diabetes and hypertension. So why are pregnant women more prone to have dissective events? So there are three main results or three main factors. The first one is the role played by the hemodynamic stresses of pregnancy in producing changes in arterial structures. We all know that during pregnancy, there is an increase in basal oxygen consumption that leads to an increased heart rate, an increased and the systolic volume, an increase in heart stroke volume, all leading to vasodilatation of the vessels. The second most important factor is the independent role of estrogen and relaxin, which increase vascular compliance. We all know that estrogen has both vascular protective and destructive, vascular protective and vascular destructive effects on vessels, which would increase vascular compliance, making blood vessels more susceptible to dissection. The third one being the generalized prothrombotic state. Now, what about early pregnancy, which is the main subject of my presentation? Since the very first weeks of pregnancy, it has been shown that the sudden rapid overactivation of the sympathetic nervous system and the constant decrease of the parasympathetic nervous system activation led to adaptive cardiovascular changes of the endothelial architecture and function. I have to add that beta HCG doubling every 48 hours in the first 12 weeks of pregnancy is also a factor for moduling endothelial architecture, leading to cystic medial degeneration, elastic fiber fragmentation, loss of smooth smooth muscle cells and accumulation of amorphous extracellular matrix. So what about the treatment? Do we anticoagulate? Do we anti-aggregate? Well, we can't talk about this subject without mentioning the two main studies that led to some of the consensus results. And the first one being the CADIS trial, which showed that there was no difference in prevention of stroke or of residual stenosis and occlusion between patients treated with anticoagulants and antiplatelets. However, the TREAT-CAD trial showed that in patients with cervical artery dissection, aspirin was not non-inferior to vitamin K antagonists. So we have seen that even outside pregnancy, there is an uncertainty about the comparative efficacy of antiplatelet therapy versus anticoagulation. In pregnancy, present meta-analysis did not find significant differences between antiplatelet and anticoagulant treatments despite increased sample sizes. If either treatment is considered reasonable, and decisions should be based on individual risk-benefits analysis. If anticoagulation is chosen, we have to choose, or it is preferred to choose, a low molecular weighted heparins. So for early pregnancy, there are some particular considerations that would influence the decision making. The first one being the fetal considerations. You have to know that vitamin K antagonists cross the placenta and have a dose-dependent relationship with increased adverse outcomes such as miscarriages, stillbirth, and embryopathy. The rate of miscarriages in a large series of pregnant patients was 28% in women receiving vitamin K antagonists in the first trimester, compared with only 9% in women receiving any form of heparin. Heparin strategy in the first trimester, followed by VKAs in the remainder of the pregnancy, did not eliminate the risk of fetal wastage, in contrast to a strategy of only low molecular weight heparins. The available data that did not suggest that DOAX exposure in pregnancy carries a high risk of embryopathy. The large majority of literature supports no increase in fetal bleeding risk, congenital abnormalities in pregnant women treated with aspirin. Human data are lacking in analysis of early pregnancy fetal complications and wastage with P2Y12 inhibitors, most commonly clopidogrel, and should only be used when strictly necessary. So in fetal consideration, it is aspirin and low molecular weighted heparins that are preferred. For the maternal considerations, the first trimester bleeding risk is slightly higher in the group of therapeutic anticoagulation versus antiplatelet treatment, and there is no significant difference in the first trimester bleeding risk in VKAs versus low molecular weighted heparins. So the risk of heparin-induced, low molecular weighted heparins versus VKAs came equal. For the risk of heparin-induced thrombocytopenia, it is rare in early pregnancy. DOACs do not seem to be related to an increased risk of first trimester bleeding in comparison with low molecular weight heparins and VKAs. So for maternal considerations, in terms of bleeding risk, there is no significant difference in the between VKAs and low molecular weight heparins. However, there is an increased bleeding risk in anticoagulation versus antiplatelet treatment, making aspirin a more preferred treatment. For our patient, she was immediately put under low molecular weighted heparins. Control has been satisfying. There was no major bleedings, and the control ultrasounds were satisfying. Thank you.
Thank you so much, Dr. Khadija, for the talk. I see no questions posted, so we can proceed ahead with our speaker talk today. Dr. Shaib is with us. Of course, Dr. Shaib is one of our pioneers. He did his internal medicine neurology, followed by training in cerebrovascular research. Since then, he had held multiple positions and rose rapidly. He was director of Division of Neurology and a director of Saskatchewan Stroke Research Center, director of the WHO Center. He became eventually the University of Alberta's director of the Division of Neurology, as well as director of the stroke program. He had multiple publications, over 450s, and served on multiple editorial boards as well. Today, he will talk to us about update on antithrombotics in stroke. Welcome, Dr. Shaib.
Thank you very much for that kind introduction. I hope you can hear me and you can see my slides.
Yes.
Excellent. And I have 25 minutes still. We're a few minutes late.
Yep.
Excellent. I will start. I first of all appreciate your invitation. I would have preferred to be in Dubai, but you know, what can you do? It's minus 12 here, and I'm sure it must be 20 degrees there. So to the organizers, next time, you know, have me come over. I'll come. So this is the topic of my presentation. I have no conflicts. I have the following objectives. I'm going to move this bar because it's in the middle of my presentation here. Okay, so what I want to do is to remind you that all the symptoms that come to the emergency are not ischemic in nature. There is a differential diagnosis, and especially in the elderly, be very careful when you start them on dual antiplatelets. So there is a differential diagnosis, and once you made up your mind that it is an ischemic event, then you want to look at those with high risk versus low risk. And it's always very interesting that where we are today. I want to give you a quick brief history of how we got here, and then I'll give you some data both from the Middle East and the US on how appropriate are we with our medications, and that should wrap my presentation. All right, so the first job for me, my challenging job, is to move to the first slide. So here's to keep in mind, in our stroke clinic, about 40% of patients are not TIAs or strokes that are referred to us. In our emergency department, in fact, 52% of those who come in are stroke mimics of different kinds. So in my mind, when someone comes in with transient spells, you want to make sure that they're high-risk TIAs. We'll go over that in a minute. You want to make sure that they're what we call these non-consensus TIAs, these spells of transient symptoms. You know, I had numbness on my left side, or I was very dizzy, or, you know, I couldn't see well through my left eye or the right eye. So those are what we call, you know, maybe they were TIAs, maybe they were not TIAs, and so we call them non-consensus spells. This one was very important, the one, the third bullet. These are the cerebral amyloid-associated transient symptoms. They're very common. And you've got to be careful to recognize them, because these patients, as you know, are at a high risk of bleeds, right? So if you've got cerebral amyloid, that increases the risk of intracranial bleeds. So these patients should perhaps not be put on dual antiplatelets. Classically, they'll come in with, you know, I've had 50 identical spells or 30 identical spells. So they happen every day. So elderly people with some degree of cognitive dysfunction with repetitive symptoms, think of the CAA-related spells. And the mimics, of course, are a nuisance, but they're very common. I'm on call right now, and I came to the hospital at 4 in the morning. And I'm 67 years old. I shouldn't be coming to hospital for mimics, but they're there. They're frequent, and we have to deal with them. So what are, I'm just going to skip this slide because I just went over it with you. So what is the risk of stroke following a TIA or a minor, more severe stroke? So the TIA literature is actually very, very interesting, and I want to go over this with you. Back in the days when I first started practicing neurology and stroke, we used to see these patients in the clinic weeks to months after their TIA. So most of them would have already had their stroke. So we were left with the low risk patients. A colleague of mine, a dear friend of mine, is Claire Johnston, who in the year 2000 published this study. And, you know, it's one of those things where you say, I wish I had done it, because everyone could have done this. What they did was very interesting stuff. What they did was they picked four emergency departments in the city of San Francisco, which incidentally is less than 1/10 the population of Dubai. So what I'm trying to say is that you can do better stuff in Dubai. And they looked at emergency department. All the patients would come in with a focal event within the previous 24 hours. So they found 1,700 patients, and they basically said if they were a TIA or a minor stroke, what happens to them in the next 90 days? So here you go. In the next 90 days, 10% of them had come back with either a stroke or a recurrent TIA or heart disease. And most of these happened in the first 2 days. So this is the first time, to my knowledge, that we were able to show that a TIA is actually no different than acute coronary syndrome. The other thing they did that was very interesting was they looked at, the type of patients who came back early, and they identified these patients as those with increased focal duration of focal symptoms, the presence of previous hypertension or diabetes, and if the symptoms were actually motor or speech. So they were real TIAs as opposed to those sensory spells that I was talking to you. So they put that score in. So how many of these were present? If the risk factors were none, which is at the top here, the risk of early recurrence was very low. On the other hand, if they had focal symptoms that lasted for more than an hour, and they were, especially if they were motor in the presence of previous diabetes or hypertension, you can see, look at this, almost 25% of them had an event, and most of these events were occurring very early, right? So they put together the hypothesis of a possible high-risk patient. So subsequently, Peter Rothwell and his group, this is Oxfordshire data, published what is now called the ABCD score, right? So age over 60, hypertension, focal symptoms, duration more than 60 minutes, and diabetes. If more than 5 of these are present, so a ABCD score of 5 or more, they're considered high-risk patients, right? So we know how this was established, and we also know what a high-risk patient is. And the high-risk patient, in your practice, I can see more than 1,000 people there, in your practice should be seen the next day or the same day. It's like an acute coronary syndrome. So symptoms resolving within 24 hours are TIA. Symptoms that don't resolve are a stroke, motor, speech, and we've added now, if imaging shows severe stenosis in an ipsilateral symptomatic artery, if your imaging shows a new infarct, if the patient has atrial fibrillation or evidence of intracranial atherosclerosis. These are your high-risk patients. They're TIAs if it's less than 24 hours. They're a stroke if it's more than 24 hours. Very important that you understand this, because on the background of this, the treatment is based. Minor stroke, major stroke, high-risk TIA, and that's when you start thinking of dual antiplatelets. So that was my second important message for you today. First, is it a stroke or not? Secondly, is it a high-risk patient or not? So let's now go into a brief history of where it all started. And I'm showing you this history for a very important reason. I want to show this to you because I want to bring in all these studies that have been done. So, you go back from 1987 to literally December of 2023. So I'm going to cover all of this for you. The first study was, in fact, before my time. This is called the Canadian Cooperative Stroke Study. It was published in the New England Medical Journal in 1978. I became a doctor in 1980, so 2 years before me. I wanted to show you the study because it was done in Canada. We were really proud of the study. It's called a 2x2 factorial design. So they wanted to see, is aspirin better than placebo? And if you add sulfentrazone, which was another antiplatelet agent, does that add any extra benefit? So single agent, 2 agents versus placebo. You can see that whether it's aspirin, the bottom line, or aspirin plus sulfentrazone, they're more or less the same. If you use sulfentrazone alone or a placebo, they're up there. So clearly, for the first time, there was a randomized trial showed that aspirin was great and that adding a sulfentrazone did not help. So aspirin became an established treatment at a very high dose. It was 1,300 milligrams then, but as you all know, that over time now we've been bringing it down to an extent that 80 milligrams to 100 milligrams is considered to be more or less appropriate treatment. Also, the sulfentrazone did not work. So big study, the first study, the very important study, which was followed by this study. And by this time, I was practicing, and we enrolled about 100 patients into what is a 20,000 patient landmark study. So in here, they were comparing aspirin to clopidogrel. And there's a really important reason why I want to share this with you, because I want to make sure that your practice is based within the guidelines. In here, the question was, is clopidogrel, Plavix, is it better than aspirin? And they were looking at patients, we were looking at patients with ischemic stroke, with myocardial infarction, and with peripheral arterial disease. So if you look at the graph, you know, it's marginally, Plavix is marginally better than aspirin. And at the bottom, if you look at the three groups, you're not supposed to look at the three groups because it's a combined endpoint, but really the study was driven by peripheral arterial disease. In fact, in the MI group, it was on the wrong side of unity. So overall, Plavix is better than aspirin. Plavix is marginally better, so you'll have to treat 200 patients to get a benefit. So my practice has always been that if somebody is on aspirin and they have a TIA or a stroke or an MI, make sure that they're compliant to the drug. Very frequently, and I'll show you some data from low to middle income countries later on, but make sure that they're compliant to their medications instead of switching. Right? Because Plavix has more side effects and it's more expensive also. But a really important landmark study. So here you see that the study is actually driven by the peripheral arterial disease. And there is strong data from multiple trials since then that antiplatelet, antithrombotic drugs are actually very useful. And over time, the dose went down from 1,300 milligrams to 300 milligrams to as low as 30 milligrams in the Danish study. So strong data that antithrombotic medications prevent vascular disease in patients with TIA and stroke. The next big question was single agent versus dual agents, because the cardiologists have started using aspirin plus Plavix. Our first study was this study. We were part of it, and we again enrolled a very large number of patients, I think 120 or so patients, where you wanted to look at Plavix, because the company that was doing the study was making Plavix. They wanted to show that Plavix plus aspirin is better than aspirin alone. So almost 7,600 patients. You surprisingly see that those who are on a single agent or dual agents have very little difference. This was a big surprise to us, that long-term dual antiplatelet agents were not a good idea. And not only were they not a good idea for prevention, they also increase the risk of bleeding. So the risk of bleeding on dual aspirin plus clopidogrel was significantly higher than aspirin alone. And this started roughly around 3 months. Remember this number, 3 months. I'm going to come back to that in the next few slides. So this put a stop to dual antiplatelets as a long-term treatment. Emphasizes that as a long-term treatment, it was stopped. However, remember that study from San Francisco, when that came out, here in Alberta, we started thinking that perhaps short-term treatment would be better. And so this is the first trial, a very small trial, which showed that in 62 patients, those who were on dual antiplatelets started immediately after the TIA or mild stroke, had a risk of 7% of recurrence at 90 days, versus if they were on single agent, they were about 10%. The start of dual antiplatelets for acute treatment. The bigger trials are the following. You should all know about this. One is called POINT, and the other is called CHANCE. So here is the data from, my slide is hidden, so I'm going to minimize you for a second. In here is the data from POINT showing that if you combine the two agents, your risk early stroke is 8%. If you're on aspirin alone, it's 11%. So combination treatment for 90 days was better, but you stopped at 90 days. The second one, of course, is, so this is POINT, and then CHANCE comes along that shows almost the same data. So here's the data from CHANCE. And then finally, ticagrelor also showed a similar effect. If you combine it with aspirin in the early treatment in a very large number of patients, like 11,000 patients, you can see that combination of the two, the risk of stroke is 5% versus 6%. And this was statistically significant, but we prefer a combination of aspirin and clopidogrel because that's a cheaper combination. If you've got if you're one of those patients who cannot convert the prodrug clopidogrel, then you can consider ticagrelor. Right, so this is where the combination of single agent versus dual agent became important. So anyone who comes in with a TIA or a stroke who's high risk, and the stroke has to be minor stroke, that for the first 21 days, which is our practice, but you can do it for as long as 3 months, you combine the two drugs. So what is new? So remember I told you that, I'm going to show you the data from 1978 to December of 2023. So this is the most recent paper. So most of these other studies were treating patients within 24 hours. And so the Chinese have now shown, published very like a month and a half ago, that in fact, if the person comes to you in 24 hours, 48 hours, or up to 72 hours, their combination of aspirin plus Plavix is superior to aspirin alone. So the practice until recently was that if it was after the first 24 hours, you'd probably treat them with aspirin alone. But if it was less than 24 hours, you'll use dual antiplatelets. But now I can report to you that if somebody comes in at 36 hours or 48 hours, you can still, in the high-risk patients, and we know what the high-risk patient is, you can treat them with dual antiplatelets. All right, that was the background data. And now I'm going to go into the final part of my presentation, which is how appropriate are we managing these patients. So I'm going to first show you what the appropriate treatment with a single agent is, what is the appropriate agent with dual antiplatelets, and then I'll show you the real clinical data in the real world. So I'm sure we'll all agree that for dual antiplatelets, we should have patients with a high ABCD score. I've told you what that is, and an NIH-SS of less than 4 or 5, because higher patients with bigger strokes could be at increased risk of bleeding from dual antiplatelets. We also tend to use it fairly commonly in patients with intracranial atherosclerosis lacking heart clinical data. For single agents, single antiplatelet agents, and my preference is always aspirin unless they can not tolerate it, is patients with high risk. So anyone with a larger stroke than NIH-SS of more than 5, and low risk, those non-consensus symptoms that I'd shown you earlier, and dizziness, numbness, and if you think they're still TIAs, you may put them on an aspirin. And there's a very large group of patients in whom dual antiplatelets have not been evaluated, because we've always thought that perhaps the risk is very high. Patients with recent bleeding, patients with patients who are going to go for endarterectomy, so patients with an aneurysm, for example. So I created this very large risk of a very large group of patients in whom DAPT has not been assessed, but it's not important. It's just, as long as you keep this in mind, that anyone with a large stroke, anyone with the TIA is not high risk, you should consider single antiplatelet agent. All right. So what then is our practice? How often are we using appropriate medications? And the second question is, as more and more studies are coming, is our usage of dual antiplatelet for appropriate patients increasing or not? And once I share this data with you, I will then wind up my presentation. So this is the Get with the guidelines. This is a very large group of patients, more than 156,000 patients in the US. And you can see that from 2013, when Chance and Point were published, so Point was published a little later than that, the usage in high-risk patients with minor strokes of aspirin, which is bottom in here, clopidogrel, has been decreasing steadily, and dual antiplatelets are increasing. So this is a good thing, right? We are following those guidelines, but still, almost half the patients who should be on dual antiplatelets are not on dual antiplatelets. And this practice is more frequent in primary centers and less frequent in comprehensive centers. This is again a very recent publication that's somewhat disturbing, that the use of aspirin for secondary prevention of cardiovascular disease that includes stroke in low to middle income to high income countries. So you are in here in the Middle East, which is considered to be middle income countries. The yellow are low income countries. And you can see what I'm trying to show you, that overall, approximately 40% of patients who should be on a treatment for cardiovascular disease prevention are taking the medications. And in the low income countries or middle income countries, this is very low. It's disturbingly low. 1 in 5 patients who should be on the medications is actually on the medications. What about Middle East data from Qatar? This is real data. This is registry data. And this is very important data. So we looked at this and we published it October last year. From between 2014 and 2021, almost 16,000 patients. So we looked at patients in 2 categories: TIA patients, almost 1,500, and stroke patients, very large numbers, 7,700. So of these, half of them were minor strokes and where dual antiplatelets was indicated, and half of them were larger strokes where it was not indicated. So at the bottom, if you see discharge on appropriate antiplatelet versus discharge on inappropriate antiplatelet agents. So concentrate on the darker one. In low-risk patients, where there should be monotherapy, about 65% are discharged on appropriate medicines. In high-risk patients, only less than half the patients are being discharged on dual antiplatelet agents. And similarly, in minor strokes, only a third of them who should be on dual antiplatelets are actually going home on dual antiplatelet agents. So there's room for us to improve things, right? All right, in the next 3 or 4 minutes, I'm going to wrap up so I can stay within time. I wanted to also share with you, what is the emergency room doing? So your patient goes to the emergency room. What does the emergency room physician do with these patients? And this is a survey of physicians in North America. And as you can see, they're not doing very well. They're actually doing terribly. So if somebody is coming with a high risk TIA to the emergency room, these doctors are prescribing in half these patients only aspirin alone. Most of these patients are being referred, deferred management to the consultant team. That's terrible, isn't it? So half the patients are being sent to a referring team. 46% are being discharged in aspirin, and only 5% of them are going on, only 5% are being discharged on dual antiplatelet agents. I don't know what to do with that. It's not very exciting data. So this is what our recommendations are, and I hope I've convinced you. Dual antiplatelets for high-risk TIA patients, and you should know what those high-risk patients are. It is recommended for 21 days, but you can do up to 3 months also, and for minor stroke patients also. For all other patients, use a single agent. There is no evidence that switching from aspirin to Plavix improves things. In fact, make sure that they're actually taking their medications. If the person happens to have atrial fibrillation, that's where you use a DOACs. And very, very, very importantly, I haven't had time to talk about, and I was not supposed to talk about risk factor management, but treat the hypertension, encourage them to walk, make sure they eat healthy, etc., etc. All those things are very, very important. You may note I have not talked about these things because I did not have time, and I don't have much experience with cilostazol because it's not indicated for patients in North America. We use it in peripheral arterial disease because it causes some vasodilation, and prasugrel is a analog of clopidogrel, and it's supposed to act faster. So if you give a loading dose, it kind of defeats the purpose. There's a study called COMPASS where aspirin low dose plus rivaroxaban 2.5 milligram twice a day can be used in higher risk patients who have failed treatment with the dual antiplatelets that I talked about. But I think those patients should be referred to a stroke expert before they start them on these dual agents. And like I said a moment ago, treat atrial fibrillation with anticoagulation. All right, I am going to stop here. If I left a couple of minutes for questions, but this is kind of the end of my presentation. Thank you for your attention.
Thank you. Thank you, Dr. Ashraf, for this excellent presentation. I think that the Q&A question will be at the end of the session, and I will introduce the next speaker, who is Anna Catarina Francesca, who is a neurologist and holds of PhD medicine from the Faculty of Medicine, University of Lisbon. She completed her master's in public health from Harvard University. She is a head of the Cerebral Hemodynamic Laboratory at Hospital de Santa Maria in Lisbon, Portugal, and a researcher in Institute of Medicine Molecular. She is member of WSO Research and conference planning committees and member of the editorial board of Stroke International Journal of Stroke. So she will talk about precision in medicine on stroke. You can start, Professor Catarina Francesca.
Okay, thank you very much for the nice words and also for the kind invitation. I hope you managed to see my slides. Yes? Can you see my slides?
Not yet, no.
Okay. I don't know why, but
not yet.
Doesn't allow me to share the slides.
Okay.
I think now it's possible. Okay. I think you can see them now, right?
Okay, yes, that's right.
So thank you very much. So I'm going to talk to you about what is precision medicine, what precision medicine implies, and I'm going to talk to you about some current and future applications in stroke. I'm going to show you how in some areas we are already applying precision medicine to stroke and what lies ahead in the future. So first of all, we need to define what's precision medicine. And if you go through, you'll see that there are several definitions actually. And that definition of what precision medicine, it's going, just need to go back here, sorry. And you'll see that the definition of precision medicine that it's adopted by different institutions differs, actually. The FDA has a definition, the NIH also has its own definition, the European Medicine Agency also has its own, but you can resume it all to probably to this similar notion, that precision medicine aims to tailor the management of an individual person to the characteristics of their disease or biology, by the use of diagnostic technology to target treatment or to modify the treatment itself to maximize benefit and minimize harm. So, if you think about it, on the left side, I'm showing you what you currently do. So this is current paradigm. Whenever we in current clinical practice think about treating a patient, we tend to use the results from clinical trials and evidence medicine. And what we are actually treating is the majority of the patients. If you think about it, patients and its characteristics are distributed in a normal way using a Gaussian curve. So currently, what we are currently doing is applying the same medication to the entire population. So one size fits all. But we know that whenever we are doing this, there are some extremes, some outliers. In some cases, we are using the drug, but we know that it won't be beneficial to those individuals. And some individuals, the harms or the toxicity will outweigh the benefit. So we now have good medications. We know what we should be using in the majority of cases. So we have to change our paradigm. And that's why we have to change to a precision medicine approach. So what we are doing when we are using precision medicine is trying to use the right therapy for the right patient at the right time. So by using this, we'll be able to identify which are the patients that benefit the most from a drug, and we will also minimize the harm by excluding patients for which we know that the drug will not be beneficial and it will only be toxic. And why are we doing this now? Because we already have some evidence-based medicine. We know which drugs are good to be used. We have good therapeutics. And now we have more knowledge that has come from human genome sequencing, from proteomics, metabolomics, molecular biology, genomics, cellular technology, and also from bioinformatics. And by using all of this knowledge, we can now start to use a precision medicine approach. And this is something that governments also want to employ, also want to empower patients and researchers to use. And actually in 2015, the President of the United States at the time started the Precision Medicine Initiative. This approach started to be used in cancer because if you think about it, it was simpler and easier to use in this field of knowledge. But the long-term goal right now is to try to apply the range of the knowledge that we have about precision medicine to other areas as well. And it's not only the US government that has applied efforts in order to use a precision medicine approach. Also China, the United Kingdom, Nordic region countries, also Switzerland, as well as the European Union, have also developed efforts in order to increase research on personalized medicine. And even the European Medicine Agency has thought about how precision medicine has to change and will be applied to new clinical trial design. They are thinking that by using precision medicine, probably we'll have to think about also the evaluation of subgroups and start to use biomarkers. And we also have to think about the possibility of using data derived from several independent studies, not only from one clinical trial, in order to increase the generalizability and external validity of the results. So it really will change the way how we practice medicine and stroke. So how can we apply precision medicine in stroke? First of all, when you think about stroke, currently the term stroke is very heterogeneous because you can be talking about hemorrhagic stroke and also ischemic stroke. So if you want to apply precision medicine to stroke, we have to start to think in a more homogeneous way, and you also have to compromise the field and the knowledge that we have. So we can no longer think about ischemic stroke as a whole. Probably you have to, and you probably also think, when I think about it, patients with small vessels disease have a different pathophysiology from patients with large vessels disease. And patients with undetermined stroke etiology that are currently considered as ESOs probably also have to be divided in small subgroups. So we have to study these patients in a homogeneous way, trying to group them and trying to know more about their phenotype so that we'll be able to know more about the pathophysiology and then to have specific treatments for these specific stroke etiologies. So we cannot continue to think about stroke as a heterogeneous group, but we have to try to gather these patients that have common characteristics in order to be able to apply specific treatments to these patients. And what do we need to do this in order to do this? First of all, we are going to need to use big data. And in order to use this, we are going to need to use electronic hospital records as well as administrative data. And there will have to be places on which you can have the long-term storage of this data, of clinical data. This data will have to be stored. And for that, we are going to need adequate logistics, infrastructure, and also technology. And also, there's a very important point. We need to standardize the definition of the terms that are currently using. For example, if you think about when you think about the variable hypertension, we have to be sure that we all agree in what hypertension refers to. For example, what do you mean when you think that the patient already has hypertension? Are you saying that taking into account its personal history? Have you gone through health records? Are you thinking about the specific value of blood pressure? So we really need, in order to practice precision medicine, also to standardize the definitions. And it's something that the National Institute of Health has already launched, stroke-specific accommodated elements. And the idea is to try to see if stroke clinicians and researchers can speak the same language, and therefore to have homogeneous clinical data so that it can be reliable analyzed for outcomes predictions across studies. So it's really very important to be sure that we are talking about the same thing. Another thing that we are going to need are biobanks. So biobanks are places when you can store large quantity of biological samples. And biological samples include not only blood, plasma, but also, for example, cerebrospinal fluid. You can also have some surgical specimens. Whenever you do endarterectomy, for example, you can store the tissues, or whenever you take the thrombus after performing mechanical thrombectomy, that's also can be stored, and that can also be analyzed. So biobanks will allow you to gather a lot of information about a large number of people. And in the last years, actually, a lot of efforts have been done in order to establish multinational, multi-center collaborations and consortiums to collect this biological data in biobanks. And examples of that are, for example, the International Stroke Genetics Consortium, the Metastroke Collaboration, and also the NING Science Network. So efforts are being made to establish large networks. Another thing that we are going to need to use in order to analyze all of this data is bioinformatics. You're going to need to cooperate to a bioengineer. So bioinformatics is important in order to analyze all of this data, but also for data collection. It can hypothetically extract automatically the information from the records of the patients. And the idea is that it may be useful to optimize the diagnosis, to optimize the prognosis, to collect the data, and also to optimize the treatment. So like I told you, precision medicine in stroke might still be in its infancy, but actually, currently, there are some evidence that we are starting to use precision medicine, and I'm going to tell you also about future applications. So one field in which precision medicine has been applied is to increase the diagnosis of monogenic cerebrovascular disease, mainly related to small vessels disease. Actual precision medicine with genome sequencing technologies and availability of large-size control databases have been instrumental for recent identification of genes involved in other monogenic small vessel disease. For example, carousel, PADMAL, autosomal dominant HTT-1 small vessel disease. And the list keeps increasing. Probably the most successful case was the finding of what CADASIL is, of this specific group of patients. Currently, we know what's the pathophysiology behind CADASIL, and we know what are the symptoms, how it is transmitted, and hopefully in the future we'll have new treatments that are specific for this group of patients. And this is precision medicine at its best. So it's knowing more about the phenotype of these patients, about the pathophysiology, and hoping that a new treatment in the future could be applied specifically to treat these patients. There are some ideas about the application of precision medicine in primary prevention. So currently, we know that the risk of ischemic stroke derives from an interaction between our genes and the environment. And these genes and environment end up influencing the appearance of vascular risk factors. So we know that many of the established and emerging risk factors, such as arterial hypertension, diabetes mellitus, and hypolipidemia, have both genetic and environmental behavioral components. And genome-wide association studies, GWAS studies, have started to identify common gene variants for these risk factors. So we now know most of the alleles that are behind these vascular risk factors. There are studies that have been developed to assess the effect of the cumulative burden of risk alleles of stroke risk factors. And they do that by combining them in a measurable and so-called genetic risk score. And genetic risk scores are beginning to emerge. So if you think about it, we have clinical risk scores, which take into account the demographics or the risk factors of the patient itself. But when we talk about genetic risk scores, we are thinking about combining the data from genetic studies and then the specific allele that the patients have with the risk factors. And that, hypothetically, may give us a better idea about what's the risk of the patient of developing a stroke. So the growing number of known disease susceptibility loci further allow the creation of polygenic risk scores, which can heighten our ability to stratify risk and determine which individuals will benefit most from targeted interventions. So if we will take blood for the patient and analyze his DNA, we'll be able to know which patients are at high risk for having, for example, a stroke or coronary heart disease, and which ones are at a low risk. So by knowing this from birth, if we know that the patient has a priori high risk of having a disease, we can act upon that specific patient, trying to reduce the risk that they will develop the outcome. So this is really primary prevention, because we are acting before the patient has had the event, stroke or coronary heart disease. So that will be really a great development, being able to act before the risk factor first appears in patients while they're still infants. So Mark Dishkens and his group did a study in which they went to analyze this genetic risk score that they developed, and they compared its prediction ability when compared just with using common vascular risk factors that we currently know. And what they showed is that actually these genetic risk scores, when combined with the vascular risk factors, are better to predict outcomes, namely the occurrence of stroke. And these results were validated using the UK Biobank data. Another field in which precision medicine is currently being applied is for the selection of patients to do reperfusion therapies. So acute stroke imaging currently is a very good example of a current application of precision medicine to stroke. So what do we know now? That contrary to what was known in the past, that we thought that there were these fixed and rigid time windows to treat patients, for example, 3 hours first to do endovascular thrombolysis and then 4.5 hours or 6 hours to use mechanical thrombectomy. Now we know that it's not necessarily rigid like that. So time is not absolute, but relative actually in terms of stroke treatment. And by using advanced perfusion and electrophysiology imaging, we can add another level of phenotypic precision. So we are using an individual approach. When we are using advanced imaging to select patients, we are actually applying precision medicine for these specific patients. So therefore, imaging can be viewed as state data for these individual patients, as opposed to trait data that's represented by genotype or phenotype. And the precision choices for intervention based on imaging were largely responsible for the success of the recent endovascular trials. So it was the use of precision medicine by using individual characterization, for example, of the core, of the membrane and mismatch of these patients that allowed us to expand the current windows to do reperfusion therapies. And it's a very good example of the current application of precision medicines in stroke. So what about in the future? Can precision medicine help us increase the number of patients that are currently treated or are currently undergoing perfusion treatments? Well, we know that time is brain, but the question is, can we expand time? Can we increase the time that the patient is resistant to ischemia? Well, we know that there are some protective responses, and we know that the collateral circulation, the increase in blood pressure, the activation of the autonomic nervous system, the increase in oxide nitric and vascular endothelial growth factor and adrenomedulin that help us to support or increase the time that we undergo ischemia. Also, the hypoxia-inducible factor 1 response and suppression of neuronal activity in protein also help us to increase the ischemic threshold. And these two things used together, increasing collateral flow and increasing the ischemic threshold, help us to prevent ischemia. So how can we increase the time or increase the number of patients that are being treated by using precision medicine? Actually, we can, and one idea is try to improve collateral circulation. And we know that collectors are also actually very important because there are some studies that have shown that time to treatment was a predictive outcome only when collaterals were excluded from the model, indicating the importance of collaterals for the time window. So if we can actually improve or magnify or enhance collateral circulation, probably we'll be able to increase the time that patients undergo ischemia. There are some translational studies of the genetic variability in cerebral murine collateral circulation that prove important in understanding pathophysiology of collateral response in acute ischemic stroke. And this may help us to develop strategies to enhance collateral circulation that may expand time, some that may be non-pharmacological and others pharmacological. Actually, there's an ongoing biomarker study based on animal discovery of a gene that controls up to 80% of variation arterial collaterals. This gene is CAVQ1, and we know that it's very important in animals in order to establish the collateral circulation in functional outcomes. We really don't know if this can be applied also to humans. So currently, a translational study is underway to establish if this gene is linked to collateral score in functional outcome in humans with acute stroke. And if it succeeds, individual patient collateral genetics could be used to select patients for endovascular therapy. Also in secondary prevention, we are currently starting also to apply precision medicine. Personalized therapy is often used in stroke medicine, if you think about it. Sometimes, in order to get the blood pressure right in some patients, often we try and do a trial and error approach, increasing or decreasing the doses or increasing more blood pressure, lowering medication. But pharmacogenetics may really help us to enhance secondary prevention. So pharmacogenetics refers to the study the genetic variation in drug response. And we know there's an influence of genetic variants on drug response, including the efficacy and toxicity of drugs. And genotyping has already begun to influence medication use, actually. So clopidogrel, the last speaker just talked about clopidogrel. Actually, we know it's a prodrug, so it is inactive and it needs to be metabolized by the cytochrome CYP2C19 in order to be active. The fact is that there is a large genetic variability in the allele that some patients have. So if you have one allele, you have full enzymatic activity. But if you have alleles with loss of function, like 2, 3, 5, or 17, actually, that means that clopidogrel will not be so fully metabolized. So we'll have less amount of active substance. And therefore, the platelet aggregation function will be differently affected. We know currently now that carriers of at least one CYP219 reduced function alleles, that happens in about 25 or 30% of the population, will have less than 1/3 of the active metabolite of clopidogrel. So they'll have reduced plateau inhibition. And there's therefore the idea that clopidogrel may be less effective for secondary prevention of stroke in carriers of this loss of function allele, which are present in about 25% of white patients and in 60% of Asian patients. So in 2021, there was a Chinese study, the CHANCE-2 trial, that tried to know if it was really important to identify these patients with loss of function. So what they did was a randomized clinical trial, and they randomized patients with loss of function allele carriers either to receive clopidogrel plus placebo, clopidogrel plus aspirin, or clopidogrel plus ticagrelor. And it was really important because patients were tested by using a point-of-care testing. So point-of-care testing allows you to have an immediate result that is done at the bedside of the patient. So you can immediately know which is the genetic variant of that patient in a way in which you don't have to wait for the lab results. So it was really a breakthrough to use this point-of-care testing in these patients. And what did the CHANCE-2 trial show? It included around 11,000 Chinese patients, and it did show that patients with loss of function alleles of clopidogrel benefit from the use of ticagrelor instead. There was an increase in bleeding overall, but there was not increase in severe or moderate bleeding in patients that use ticagrelor. So it seems that in specific cases, genotyping the patients, it's helpful to reduce events and it increased efficacy of the drugs. So is CHANCE-2 the beginning of a genotyping era in stroke? Well, you should not forget we already have used drugs in which you used a precision medicine approach. For example, warfarin. If you think about it, warfarin was the paramount illustration of personalized medicine, because the dosage of warfarin must be individualized for each patient based on the patient response in terms of time anticoagulation of NR. Because warfarin needs to be metabolized by two enzymes, CYP2C19, and it acts upon the vitamin K epoxy reductase. So if you use genotyping, you'll know exactly which drug amount of warfarin to give to these patients, and you will have more of the time of these patients in a therapeutic range. And actually, the FDA has approved pharmacogenetic testing of these genes for warfarin, and has provided genotype-specific ranges of those. So if you used genotyping in order to select the amount of warfarin to give to patients, you are going to increase the time in therapeutic range. And this has already been shown in a clinical trial that was sponsored by the European Union. So the idea is that precision medicine will not ease your work, actually, because you are going to need to know more about the patients, genotype them, do more blood analysis. But at the same time, you know that the patients will be under the right treatment. You are going to minimize the harm. So it's not the easiest way, but it's probably the more effective way. But you can tell me, but we have NOACs right now, or DOACs, like they are also known. But actually, when you think about it, when you are thinking about NOACs, you are going back to our old paradigm of using one size fits all. When you are using a NOAC, you know that patients are going to benefit, but also some patients that won't benefit the drug, and they are going to have also more adverse events. And actually, there are also some genetic clues for the response to the new oral anticoagulants. So we now know that dabigatran also can be influenced in its metabolism by specific allele, as well as ALT+. So as you can see, there's a lot we have to learn about pharmacogenetics. Actually, as time goes by, more and more we know about how drugs are metabolized and how genes interfere with this metabolization. An example also where personalized medicine can be applied it's, for example, to do the retroarterial appendage occlusion. Currently, it's an alternative approach in patients that continue to have events, although they have been anticoagulated or cannot be anticoagulated. So precision medicine can be used to design specific occluders to these patients in order to increase also its efficacy and improve outcomes. RNA therapeutics is also something that can be used in the future. They are dynamic chemical regulators that can be modified and edited, and there have been a lot of focus in developing novel therapeutic schemes. And actually, there are under development some RNAs in which the efficacy and to improve the conditions like hypercholesterolemia, diabetes mellitus, and atrial fibrillation are being studied. So there are some problems in the clinical application of precision medicine. We know that we need to still show if it's a cost-effective approach. We need more point-of-care tools to improve physician decision-making, and we need more data also to demonstrate the efficacy of using this genetic information to improve health. We need similar clinical trials like to one that was conducted by the Chinese. So concluding, precision medicine for stroke, it's still in its infancy, but it's already begun to shift from a one-size-fits-all medicine towards a more precise and individualized approach. So we now have available evidence-based therapies. We have treatments that work, but to redefine their use to individuals should be the subject of research for years to come. So it's also very important, just to finalize, to think that we have precision medicine, we have all this technology, but it's still very important to do a personalized medicine, to have into account the education of the patient, socioeconomic status, the individual preference, and also think about how patients will have a need to comply with medications in order to get the best outcome. Thank you.
Thank you so much, Dr. Francesca, as well as Dr. Shea, for an excellent talk today. We can start with the question and answers. Whoever has a question, please feel free to post it on. I'll start with the first question for Dr. Shoaib. So the first question is, how will you differentiate between a TIA and syncope based on history and investigations, as both cases return to full normal GCS within a short period of time?
So just let me try and understand the question. How would we differentiate between a TIA and?
Syncope.
Oh, syncope. Well, that's it's a very good question, because in those 1/3 of patients that are not strokes that come to our clinic, syncope is one of the commonest one. So syncope is never a TIA. I mean, somebody will say, well, what about basilar artery TIA? Maybe. I haven't seen it. So people talk about, what used to be called vertebrobasilar ischemia. Those are such rare things, and you need to have definite proof that your basilar artery or your vertebral arteries are occluded, and there's severe postural hypotension. So honestly, if somebody has syncope, so if somebody passes out and then recovers, it's not a TIA. That's my simple answer.
Thank you. I think we are
I'm curious what Anna would say. What about in Portugal? Does syncope end up coming to your clinics too?
Sorry?
So I was going to ask you whether syncope comes to your clinics too as a TIA.
Sometimes. Yes, sometimes we are asked to evaluate patients that have had a syncope. It's very important to do a full clinical history and also to talk with a witness if there's some. Yeah.
If somebody passes out, patients with TIAs don't pass out. Patients with posterior circulation TIAs rarely pass out, actually. Most syncopes are non-focal symptoms. We can always use precision medicine to find them, right?
I think clinical history still has an important role.
I was just joking. I wanted to
it's very important.
Later.
Yeah.
Any other questions at all?
Yes, another question, I think. Does age of the patients matters for the management and intervention after stroke? Does age of the patients matters for the management and the interventional after stroke?
Age of the patient matters for managing prevention
after stroke. Yes, I think prevention.
No,
yes.
it doesn't matter at all. I mean, I think what we have shown in clinical trials is that if anything, thrombectomy works better in older people. So we treat patients who are 100-year-old It's a matter of your resources. Do you have the resources or not to do that? And similarly, if somebody has atrial fibrillation and they're 90 years old and they're mobile, if you don't treat it, the risk of embolic stroke is highest in the older patient with AFib, right? So I think it's not the age alone. If they're very old and they're demented or extremely ill, which is very few patients, then the patient and their family may help you decide. But outside of that, age in itself, if somebody is 80 years old and walks a mile every day, age is irrelevant, totally. You treat them as aggressively as you would somebody who is 50 years old.
Keeping it in the same kind of scenario, we have also a question about antiplatelet and end-stage renal disease for secondary prevention. Since there is a plate dysfunction, even with extensive dialysis, does antiplatelet help or not?
So chronic renal disease is a very high risk patient. We used to talk about the cardiometabolic syndrome. So now the word renal has been added to that. So it's renal cardiometabolic syndrome, which means that if the renal disease is present, it actually significantly affects your prognosis. And in the Middle East, it's common because of diabetes, right? Diabetes starts at an early age. There's not good compliance. So if you have renal disease, renal disease is bad prognostically. And also the risks of complications increase. So bleeding increases. However, because at every stage of renal disease, patients who are on appropriate antithrombotic agents, they do better than those who are not on it. So high-risk population, in the high-risk population who are not on antithrombotics, they're at even higher risk. So I would treat everyone unless unless a nephrologist tells me not to treat, which I can't remember the last time that's happened. We always treat our patients with antiplatelet agents. With anticoagulants, some of them are cleared by the kidneys, right? So in those cases, you may be careful with the DOACs, especially if it's dabigatran, for example, which has got a higher renal clearance compared to rivaroxaban or apixaban or edoxaban. So I think it's a very complicated question. It depends on what the GFR is, and if it's anything lower than 15, then you need to start consulting with your nephrologist. I want to ask Anna's opinion also. What does she think?
Yes, regarding antiplatelets, there's no contraindication in stage renal disease. But like you said, regarding the questions, we have to be careful. We have to check the glomerular filtration rate before starting NOACs, because those need to be adjusted in some cases. In cases where the glomerular filtration rate is very low, below 30, only warfarin can be used. There's some controversy regarding if it's really useful or not, because it also increases calcification of the arteries. But below 30, warfarin is the safest anticoagulant you can use in this context.
It's okay for this question? Another question, I think there are a lot of questions. I don't know if we are going to treat all these questions.
I think we have time for at least one more, Dr. Salma, if that's okay.
Just one? So, what's the difference of clopidogrel and ticagrelor in TEA? Can we give also ticagrelor, or clopidogrel is more safe to pair with aspirin? It's far.
I would let Anna answer that one. It falls into precision medicine.
Yes, so ticagrelor actually has increased bleeding risk. So, and it has been tested in clinical trials. It included patients with a higher risk TIAs. So, the clinical trial that tested it included patients with ABCD score higher than 6, because they knew that to maintain the balance between the benefit and risk, they would have to have patients that would benefit the most from this drug, because it also has a higher probability of inducing bleeding. So you can use the current guidelines, taking into account the bleeding risk, actually state that you should prefer to use aspirin and clopidogrel in patients with TIAs, actually. And but if you have you don't have a response to clopidogrel, or if you are have a higher risk TIA, you can consider to use the ticagrelor. But you have to have into account that ticagrelor use is linked to a higher risk of bleeding. And it should not be used also in large ischemic strokes, because it increases the risk of hemorrhagic transformation. So if you have more than a minor stroke, you should not, as a rule, use ticagrelor, because it has an increased risk of hemorrhagic transformation. You should prefer, in that case, to use clopidogrel, if you have to think about the comparison between the two of them.
Thank you.
Thank you so much for both Dr. Francesca, Dr. Shoaib, as well as our resident for the cases. Thank you so much, Dr. Telma, for helping
Thank
us
you. You're
moderate
welcome.
the questions, and to the audience. I know we were a bit past time, but this has been a great interactive round, I would say. And inshallah, we'll see you around for the next rounds.
Thank you all. Bye.
Thank you.
See you
All the
next
best.
time, inshallah. Bye-bye.
Inshallah.
Thank you. Goodbye.